Welcome to Medical Specialists Associates Topics in Critical Care Medicine. I am Christopher Voss, MD, MS, FCCP, Board Certified in Anesthesiology, Critical Care Medicine, and Neurocritical Care Medicine. Pressors are vital agents used in critical care settings to manage hemodynamic instability, particularly in cases of shock. These drugs work by constricting blood vessels, thereby increasing vascular resistance and elevating blood pressure. Understanding the biochemistry, physiology, and appropriate dosing of each pressor is essential for their effective and safe use in clinical practice. This guide will delve into the detailed mechanisms, physiological effects, dosing guidelines, and clinical applications of the most commonly used pressors, providing a comprehensive understanding for critical care professionals. Biochemistry and mechanism of action. Epinephrine. Epinephrine is a potent inotropic vasopressor that stimulates both alpha-adrenergic and beta-adrenergic receptors. Its primary action is on beta-1 receptors, leading to increased heart rate and myocardial contractility, inotropy, and on alpha-1 receptors, causing vasoconstriction. This dual action makes it effective in managing hypotension and cardiac arrest by increasing cardiac output and vascular resistance simultaneously. Dosing. Initial dose, 0.01 to 0.03 micrograms per kilogram per minute. Titration. Increase by 0.01 micrograms per kilogram per minute. Increments as needed. Titration. Increase by 0.01 micrograms per kilogram per minute increments as needed. Norepinephrine. Norepinephrine primarily stimulates alpha-1 adrenergic receptors, leading to vasoconstriction and a subsequent increase in systemic vascular resistance and blood pressure. It also has mild beta-1 adrenergic activity, which may increase cardiac output slightly. Norepinephrine is often the first-line agent in septic shock due to its potent vasoconstrictive effects. Dosing. Initial dose, 0.01 to 0.05 micrograms per kilogram per minute. Titration. Increase by 0.01 to 0.05 micrograms per kilogram per minute increments as needed, depending on the clinical situation. Phenylephrine. A pure alpha-1 agonist, phenylephrine causes significant vasoconstriction without the direct cardiac stimulation seen with other pressors. This makes it particularly useful in patients with tachyarrhythmias, where an increase in heart rate would be detrimental. Phenylephrine is often used in settings requiring rapid blood pressure control, such as during surgery or acute hypotensive episodes. Dosing. Initial dose, 0.5 to 2 micrograms per kilogram per minute. Titration. Increase by 0.5 micrograms per kilogram per minute increments as needed. Maximum dose, up to 5 micrograms per kilogram per minute, or a fixed bolus dose of 50 to 200 micrograms every 10 to 15 minutes. As needed. Vasopressin. Unlike catecholamines, vasopressin works on vasopressin, 1 receptors in vascular smooth muscle, causing vasoconstriction through a different pathway, which is particularly useful in refractory septic shock or cases where catecholamines are less effective. It has been shown to be effective in both adult and pediatric critical care settings. Dosing. Typical dose, 0.03 units per minute. Fixed dose. Maximum dose, typically not increased beyond 0.03 units per minute in septic shock. Higher doses may be used in specific circumstances, e.g. 0.04 units per minute, but this is less common. Dopamine. Dopamine's effects are dose-dependent. Low doses predominantly stimulate dopamine receptors, leading to vasodilation. Intermediate doses affect beta-1 receptors, increasing cardiac output, and high doses stimulate alpha-1 receptors, resulting in vasoconstriction. Due to its variable effects and the availability of more predictable agents, dopamine is less commonly used as a primary pressor today. Dosing. Low dose. Renal dose, 1 to 3 micrograms per kilogram per minute, primarily for renal perfusion, though this use is controversial. Intermediate dose, 3 to 10 micrograms per kilogram per minute, targets beta-1 receptors, increases cardiac output. High dose, greater than 10 micrograms per kilogram per minute, predominantly alpha-adrenergic effects leading to vasoconstriction. Physiological effects and clinical implications. Hemodynamic modulation. The primary effect of pressors is the modulation of blood pressure through vasoconstriction. This is crucial in maintaining perfusion pressure to vital organs during shock states. However, the increased systemic vascular resistance can lead to reduced cardiac output in patients with compromised myocardial function, requiring careful titration and monitoring. Impact on organ perfusion. While pressors increase systemic blood pressure, they can also lead to adverse effects on organ perfusion, particularly in the splanchnic circulation. The use of Vasopressin, for example, has been associated with reduced blood flow to the gut and kidneys, although it may help wean off other catecholamines. Neurohormonal regulation. Pressors like norepinephrine and epinephrine also impact the neurohormonal axis, influencing the release of endogenous catecholamines and other vasoactive substances. This interplay can contribute to the long-term pathophysiology seen in chronic shock states or prolonged critical illness. Advanced biochemical pathways. Receptor pathways. The action of pressors at the receptor level involves intricate signaling pathways. For instance, the stimulation of alpha-1 adrenergic receptors by norepinephrine leads to a cascade involving phospholipase C, inositol triphosphate, IP3, and diacylglycerol, DAG, which increases intracellular calcium and causes smooth muscle contraction. Interaction with nitric oxide. Vasopressors can also interact with the nitric oxide pathway. For example, nitric oxide synthase inhibitors, like diphenyliodonium, have been shown to potentiate pressor responses by reducing the vasodilatory effects of nitric oxide, further contributing to vasoconstriction. Role of angiotensin II and III. The conversion of angiotensin II to angiotensin III within the brain plays a critical role in the pressor response. These peptides act on angiotensin II type 1 receptors, leading to vasoconstriction and increased blood pressure. The relative potency and duration of these effects are critical in the context of central blood pressure regulation. To learn more about critical care medicine, visit us at our website, www.medspecialists.net, and subscribe to our YouTube channel.